they actually let us stay there, which is unheard of, really. They did sort of suggest to Marcus halfway through, would he like anyone to go? And he made it quite clear, no, we either all stay or we all go. So, but yes, so I applaud them, and it was actually done within a couple of hours. So I think our appointment was something like 9:30, 10. So by lunchtime it had been done. And on the Monday I'd been given a couple of appointments, and they'd rung me up and they actually asked me, what do you think the outcome is? And I said, I know he's under the spectrum. Oh, he's on the spectrum, and indeed he was. So how did that make me feel? I was really pleased. Having said I was really pleased, I was actually quite annoyed as well that it'd taken 19 years with people telling me it was all in my head, and he was sort of mimicking other people. So I was relieved. I probably got a little bit overexcited and thought, oh yes, everything will come into place now. But in fairness, although Marcus in 12 months has had 2 support workers, the first one did fail. He didn't have the right experience. But this support worker with her other colleagues is working very well. And this is a young lad who doesn't like change. He doesn't like, if someone says they're going to come, he expects them to come. If somebody else comes, he doesn't like it, and he's actually dealt with it remarkably well. So, although I suppose I thought, yes, I wave a magic wand, it did take a while, but yes, the support for him is there, but it's it's people understanding him. And I think, certainly from my point of view, he's very good at masking. And so although I am cross with the school, given that it's a specialist school, if a young person is masking, need to, although I don't want to think like that, you actually have to think on, there's 2, six of one, half a dozen of the other, and you've got to appreciate that actually if someone is masking, it's not so easy to maybe identify. But I think from a specialist school and their specialisms, and his severe anxiety as well, and other things that they did see, I was a little, I felt that maybe things could have been sort of perhaps if it had been sorted out and he was younger, maybe he wouldn't go to college. I tried day centres, he wouldn't do that, or care. And these were places that his actual peers who'd also left school at the same time would also be going to, but he just wouldn't even acknowledge it. If he went once, that was enough. So yes, I'm pleased now, and I think we are on the right track. There's going to be lots of bumps in the road, but I think we're there now. I think my main thing is that he's 21 this year, and it's so sad. It's sad for him that it's taken until a lot of pushing by me and recognition that actually maybe my thoughts weren't me wanting him to be. Actually, it was correct. My initial I thought.
So, Mark, Jackie and I have spoken about this quite a lot. So, Marcus is open to community paediatrics. So, it's how do we listen to parents and carers, and that challenge of wanting to speak out as a parent, but then not wanting to be the difficult parent or be perceived as being the problem, and walking that really fine line, and how we enable carers to do that, and how we enable clinicians to listen without that kind of perception as well. So we've talked about that a lot.
Okay, thank you, Jackie. I won't say any more now. I have a number of questions, but I'll open it to colleagues. But I mean, first of all, thank you for coming along and telling us, because actually it's really important we understand feelings, because patient experience is so important, and and I widen that out to patient and carer experience and advocates experience. It really is important to us, and it's something that we probably don't hear enough about. So how people feel is really important. Can I hand over to Janet, who's a non-executive director? Janet.
Yes. Thank you very much, Jackie, for giving us that insight into your experience, which has been really valuable and really, really informative. So my question is about you as a carer, and how we can actually ensure that we do support carers, because you've been doing this for 20 years, and it must at times have seemed quite hopeless, and I take my hat off to you that you've persevered, and now it looks as though at least you have a diagnosis, and so you can look to the future, whereas before I imagine you were sort of stumbling around. So how can we use your insight to actually support other people who might be in your position as carers?
I think first and foremost, that has sort of been touched on already, is listening to how they feel, because of sort of the person I am involved in. They keep changing their name, the Worcestershire Parent and Carer Council, which I mean, they don't support, but the point is, when we do get together for coffee mornings and such like, we can share stories. Having said that, I do understand that there are a lot of mums or dads or whoever's looking after who perhaps aren't able to, or don't feel they are able to, and that's really difficult, Janet. Especially if they're not. Although I don't want to shout out for help, I sort of looked into what was the best groups to go to. I think maybe schools and groups and GPs, perhaps, and if you're if you're taking your sick child to the doctor, perhaps just checking in on mum and just saying, actually, how are you doing? I know they don't have a lot of time, but sort of just checking in on them. I know it's really difficult and people don't want to, but maybe friends sort of saying, look, I think you need some. I mean, I've had that where people say, I think you need help, and although you don't want to admit it, you actually realise that actually you do. So it's sort of not telling the parent, but sort of giving them sort of the idea, and then obviously you can't make them, but to put that idea, plant that idea into their minds, so that they hopefully will use it in a positive way. I hope that answers your question.
Thank you, Jackie. Well, there's two other non-executive directors that would like to ask questions. We'll Tessa first and then Carol. Tessa.
Thank you. Thank you, Janet. I'm not sure whether this is a question for, sorry, Jackie. I'm not sure it's a question for you or for Natalie, actually. My question is about the transition from community paediatric services to adult services. Have we got smooth pathways to help with that transition, and what support is in that for carers like Jackie, who are having to move from perhaps familiar services into the unknown with their son or daughter, or who they're caring for?
Right, shall I answer? So you may not like the answer, but the answer is no. Why? What's the easy transition? Well, it would be helpful to, I suppose, for the information for us to. I had been explained that when he came to the end of CAMS, that was the end, and he would be seeing Marcus would we'd go on to adults, but he'd go on to the adult sort of the umbrella of psychiatry. But I don't know. I don't recall it being particularly easy. It's what can you do? I just think need better communication. But when I say that's sort of for everybody, really. That's not sort of specific. I think in society in general, I digress a bit, but I think we all need better. We all need better communication, and I think certainly in those services where you have families with young adults who, I mean, my son, as I say, 20, 21 at the end of August, would still prefer to be at school, because that's where he's been all his life. But yes, I just think better communication and sort of parents aren't silly, but sometimes I think sometimes the wording can be a little bit confusing, so that particularly so that we as parents or carers are able to then share that information with our young person, because even if the young person's with us, they won't necessarily understand. Particularly Marcus will rely on me. So I just think, yes, it's a good communication and easy speech, I think, so that I or carers can actually then share it with our young person in a way that we know that they're going to understand. Does that answer your question, Tessa?
Yeah, you said you were going to answer it with something we might not want to hear. Actually,
it was no.
You're right. You're right. We don't want to hear it, but we know we need to hear it, because actually making the transition between children's and adult services is crucial, and we want to get better at it. So thank you for your honesty. It was really useful.
Thank you, Tessa.
Thank you. Carol, and then we'll finish with Scott after Carol. Carol.
Thank you very much. Thank you very much, Jackie. And I was really pleased to hear your mention of the Worcestershire Parent and Carers community, because they really have been...
I recognised you, actually.
Yeah,
I recognised you.
You did. It's me, and I'm still here, and I'm still talking about carers. I think my fellow non-executive directors have already asked the questions I were going to ask. I think I was just going to emphasise one of the points that you made. Particularly with parent carers, what I've seen is that they focus absolutely on their child or young person, and it's really hard to get at what do you need, and how are you, Jackie, and then following that up. So I think it is really, that's one of the things we need to include in the awareness for our staff, that be a little bit persistent and make sure the person's all right, because the fact is, one way or another, there will be a lifetime of caring, and we need you to be able to keep going. And so what do we need to do to enable you to do that? I don't think that's really a question. It's more of a statement. But I think that's something for us to bear in mind. And yes, absolutely. Mentioning transitions, I'm not going to talk about it other than it is still a big issue. And the NHS is very good at seeing things in little boxes, but that's not how it looks to a carer. And I'll leave it at that. Thank you very much, Jackie.
Good. Can I just come back to Carol, talk about little boxes? I think also it's not just, I know we're here talking about the NHS, but actually it's in society as general. So in school, Marcus wasn't in the box that he should have been. He was in a totally different box. And if I can also, it was interesting that we had a friend whose was much younger than Marcus was, didn't have any additional needs, but because she was way above where she should have been, we actually found ourselves together because both of our children weren't in the right box. They were in boxes, but they weren't in the right ones.
Yeah.
So thank you, Carol.
Thank you. And Scott, finally. Scott.
Hey, thank you, Jackie. That's a hugely valuable story you've told, and there's many years wrapped up in everything you've said there. So as a trust, we're on a journey of understanding issues and looking at how we could improve those. Would you summarise your story? Would have the last 21 odd years been better if we'd listened to you better, acted upon what you'd said, and been better coordinated? Would those be three things that you'd like to see us doing differently? Or is there something else that you think, right, what you need to change is?
No, I think yes to all your questions. But yes, if I'd been listened, yes, if I'd been listened to, I think I say at the moment we're in a good place, but it's taken a long time. And I think if I'd been listened to previously, I mean, he had some assessments, but I'm not clear what assessments he'd had, and they didn't seem to have been followed through. So yes, had we actually had an assessment that actually was followed through, and he'd had the diagnosis, if he'd been listened to, and if we'd worked together, then yeah, I think things would have been different a long time ago.
Okay.
And I would be singing, not that I'm not singing your praises, but there wouldn't be the issues that I've experienced.
So and those are the kind of things we are looking to do something about, and I think your story really illustrates that. So thank you so much for giving us your experience.
You're welcome.
Thank you, Jackie. And I think Scott gives us a good segue into the fact that we refresh the trust strategy in the next few months across the summer, and the board is aware that we need to put the patient and carer voice at the centre of that strategy, so it's seen in all that we do. So your story today is very important. But I'll just a couple of things I'll touch upon. Wording. For those of us, I mean, who are non-clinicians and working in the NHS, wording is difficult to us on occasions as well. Unintelligible on occasions, don't understand the acronyms and all those sort of things. So for a patient carer that might be sort of new into a service provision of some sort, it really must be unintelligible on occasions. So we are very aware of that. And I know of various actions across the trust trying to make our communications better, because patient experience really is key to us. Yes, we know care and treatment is really important, but the experience of contact with our clinicians is really important as well. And I think you've brought that out to us very well. And I'll just re-emphasize what Tessa said. The answers which tell us things you think we don't want to hear are the most important answers, because that's where our learning is. That's where we can try and change things for the better. Yes, it's great to hear on occasions. If somebody says, your services are wonderful and we've had a good experience, fantastic, but there hasn't been that much to learn. We get so much more to learn from the patients and the carers that haven't had such a good experience. So there's never a problem in listening to difficult truths. And that's why in the trust, we very much want to hear directly from the patient or the carer, rather than on a third-party basis. So thank you ever so much for coming along. I don't underestimate what it must be like to come along talking to a screen full of people that you have you've never met before, and they live in this ivory tower. We don't, but that can be the perception. So thank you for demonstrating your bravery and your advocacy for Marcus, because that's absolutely key, is how you advocate for Marcus, and you've done it again today, and I know you'll carry on doing it. So thank you ever so much for coming along. We've all very much welcomed you, and we wish you a good rest of day. And please pass our best regards on to Marcus, because that's what it's all about, working together to try and improve everybody's lot. Thank you, Jackie.
I definitely will. Thank you, Mark.
Okay, team, thank you for that. And it's always a good start to our meeting to hear directly from patients and carers, because it does refocus our minds. And with that, we move over to Sarah's last Chief Executive report. Sarah.
Thank you, Mark. You were saying how many board meetings. I was trying to work out how many pieces of paper I'd read for board meetings over the last... I've been on a board for over 20 years. And I was thinking, how many times have I done this? Yeah, so with that to do, my last report then. As always, I've set it out in terms of national system and trust issues. So just starting with the national ones, the board's aware from emails I've sent out separately that there is a review and transformation potentially of service provision for children and young people experiencing gender incongruence. The national service provided at the Tavistock and Portman Trust is closing in the next week, actually on the 31st of March. And there is a system being set up of regional services in 5 key areas so that young people will in the future be able to access more of a regional based service. In the interim, though, there is a transition period because only 2 of the regional services will be up and running in April this year. So what all mental health provider trusts have been asked to do is to receive information about children and young people from their own geography who are currently either on the waiting list for the National Gender Service or are already under the care of the gender services that are transferring to London and the North West, but not currently open to mental health services. And just to be clear, what we're being asked to do is not to do an assessment and care of the gender incongruence. We're being asked to do an assessment of any mental health needs, because we know that a number of young people with gender incongruence also have associated mental health needs. So what we've been asked to do is to assess those children's needs. So we're in the process of the national team are liaising with all of the trusts, and we will be provided with a list of children that meet this criteria for us to review over the coming year. So just to make you aware that this is happening at the moment. There's 2 important pieces of discharge guidance and reflection come around mental health inpatients, which you can see there, which we are looking at in some detail to assess what best practice there is within these documents that we need to implement. You'll also notice reference to the mental health cluster resource groups, which some of the newer NEDs may not be as familiar with. It was a way of clustering patients depending on their level of mental health need. There was always mixed views about its usefulness. It was going to be used partly as part of the payment regime, but from a clinical point of view, there was some mixed views about how useful it was or not. But the clusters are no longer mandated, and there's a new system coming in called the Mental Health and Neurodevelopmental Resource Groups, which will feed into the payment system. It'll be coming out for statutory consultation, so we'll get quite a bit of chance to discuss it. But just to let you know, that is happening. Another important document I've mentioned is the National Confidential Inquiry into Suicide, which was published in February 2024. And this provides finding relating to people aged 10 and above who died by suicide between 2011 and 2021. You'll note there's some specific comments there around the higher risk factors for young people under 25 years of age. This report will be discussed in a lot more detail through our system-wide and trust suicide prevention forums. So more to follow on this, but just to let you know that this has been published. Just moving on to some of the system issues. Just to formally note that following a meeting with the ICB and NHS England colleagues on the 8th of February, it was agreed that we would move as a trust our oversight framework from segment 2 to segment 3 with effect of Q3. We're actually meeting on Monday to look at Q4. The reason for the change is very directly linked to the CQC report outcome of requires improvement. It's one of the categories that ICBs and regions need to consider when deciding how to segment organisations. That's not to say there aren't a number of performance issues where our performance needs to improve as well, but the main reason for the change of segment is the CQC report. Region and the ICB are working in conjunction with Scott to clearly identify what we need to do as a trust to come out of segment 3 and back into 2. So a set of exit criteria are being designed. Obviously, they need some careful thought, because if you're trying to demonstrate you're making a cultural change, it's a harder thing to really evidence in the short term, isn't it? So Scott's working with colleagues to make sure we've got that exit criteria right, and that'll come back to be shared in due course. I just mention it here for completeness, but you'll know that we've got another item on the agenda, so I will pick up the Care Quality Commission report when we get to that item on the agenda. It's item 13. I would like to say, though, in addition to the CQC report, which we'll discuss shortly, we have had an Ofsted report into Sir Jules Thorne Lodge House, should I say, 2, at Osborne Court. This is our children's replacement care service. It was inspected. It was around a month ago now, and we have now had the published report, which confirms that we have received a rating of good for that service. So my thanks to the team who've worked really hard to make that happen. It's quite hard to work in a service for staff that's dual registered for Ofsted and CQC, because actually the focus is quite different and the ask is different. So the team do really well to ensure that we meet standards in both regards. So that's a really good outcome. As you know, the second bungalow at Osborne Court for children is assessed separately. It's a slight nuance in that Ofsted don't inspect it as a service. They inspect it as a location, if you like, and they count the 2 bungalows separately. So we were expecting an unannounced, if that makes sense, inspection around now, and Ofsted actually arrived yesterday. So that inspection is currently underway, and I'm sure it's going on today as well. Ofsted are actually really good at giving you verbal feedback quite quickly, so I'll let the board know through separate means as soon as I get verbal feedback on how that inspection has gone. But that's good news for the first one, and hopefully positive for the second. Just moving on, I've noted the board changes, which Mark has already covered. A couple of other things just to formally note for the notes, though, as well as myself and Tessa's position, just to note that Martin has had his term of office extended until 30th of April 2025. And you'll also be aware Vina has been appointed as a non-exec director for a 3-year term and will be taking over the Workforce Committee from Tessa, so just for completeness. Also linked to my retirement, you'll be aware from previous discussions that Robert has been appointed as interim chief exec from the 15th of April. We reported before that there were a number of mechanisms that needed to be put in place to support Robert in that new role. So since the board last met, we have also conducted a process and confirmed that John will be appointed as the interim deputy chief exec alongside his core role as medical director from the 15th of April. Denise, who's also here today, is appointed interim director of finance with effect from the 15th of April. And Lisa has very kindly agreed to take on board the role of senior information risk owner. So just to note all of those potential changes with the board arrangements, and thank you to everyone involved for helping us to progress that, because it's really positive for me in particular in terms of handing over with all those arrangements clear and in place. So I think that I really am hopeful that that means there'll be a seamless transition and that'll work really well. On the bottom of the same page, I also refer to the reablement contract. The board will be aware, but we thought it was important to note it here, that Worcestershire County Council have served notice on some of the funding they provide to our services. That is partly about the contribution to the funding of the individual placement service in mental health, but it also covers full funding for the reablement service within our mental health services. We are therefore now going through a formal process with staff and patients around the closure of that service because the funding has been withdrawn. The funding has been withdrawn with quite short notice from the 31st of March. So we don't propose to reduce the service that quickly because we don't think that would be appropriate for staff or patients, but we are aiming at a transition before September. So I'm sure Matthew might comment further on this later on in the ops report. Just to note, Link Nurseries, Again, some board members will be much more familiar with this than others, but Link Nurseries is a site in Powick. We used to manage services from there as trust as part of our opportunities for supporting people with mental health needs to recover and provide vocational services and activities. There's been a long conversation with board around this service, and following a redesign that took place, I can't believe it's nearly 8 years ago now, Sue, there was a change, and Warwickshire College Group actually took on the lease and started to manage the service as a community-based horticultural centre. We're now at the point where this needs to be reviewed. We are the landlord in this situation, but the really important thing for the board to note is that we can only have an arrangement of this nature if we can clearly demonstrate that the use of the building is to support mental health needs and purposes for people with mental health conditions. So that's really important for the board to bear in mind. So the college have given notice from ending in June 2024. So we are now about to start a more formal process so that we can identify the next steps. But this will potentially need to come back to board because it is about board being assured as to the purpose of the future use of the building, because obviously we have requirements on us as to what we're required to do otherwise with that building if it's surplus to our requirements and to the purpose of mental health. So just to note that. The National Staff Survey results have been released now and have been published in the last couple of weeks. We're now looking at those in more detail, and they will go through Workforce Committee. And just to conclude the report, saying thank you all. It's been an absolute pleasure working with you all as a board. So thank you for all your support over the years. I thought, given Mark was going to comment, I'm going to say the same. So I really appreciate all your support. Been an honour to work with you all. And I'm really looking forward to handing over to Rob, who's going to be fantastic, leading the trust through with Mark in the coming years. So thank you all. Happy to take any questions, Mark. And as I say, I'll pick up the CQC report at the end.
Yeah, thank you, Sarah. Does anybody have any questions? Very full report, some important matters. I will pick the reablement service up now, if I may. Matthew, Sarah, whomever would comment on it. The one question I do have is the patients that are, obviously that's a service which is just lost. Are you able to inform us, one, what is happening with those patients, or are they just, quite bluntly cut adrift? And two, could that mean that they reappear somewhere else within either the social care or the NHS services? So are there some potential sort of ripples from that we need to be aware of? Because, the unintended consequences, if you like. Is that Matthew to pick up? Would that be right?
Yeah, I think Matthew will be the best person to pick that up.
Thank you.
Yep. So one of the reasons that we are having extended kind of decommissioning of the services, we want to make sure that service users have a safe ending to their care journey with us. So at the moment, we're working with nearly 170 service users who, on average, work with us anywhere between 6 months and 2 years, but they're not going to have that opportunity. So we're trying to bring things to a close safely for them and work out what ongoing care arrangements they're going to need. I have to say, look, there is a challenge in that this is a unique service. It's a recovery-based service. It's a service that tries to help people get into voluntary work, get back into employment, get back into education, and there really isn't an equivalent service available in Worcestershire. So we're trying to link people in with other types of provision as best as we can, but there will be a significant number of people who do not benefit in the way that they would have done and risk being socially excluded. I think that has to be acknowledged as a bottom line here. There's some of these people, I strongly suspect, would at risk of having a relapse in their mental health condition as a result of not having the type of ongoing community support which they would have received through the reablement service. We're aware of that, and we're working with our community neighbourhood mental health teams in anticipation of that. But it's a great loss, and there's no two ways about that.
Okay, thank you, Matthew. And just on that, make it clear, obviously, we understand the reasons the County Council are withdrawing funding. They're under tremendous financial pressure, local government. We see it in the press all the time. So there's, we fully understand that decision. But of course, from your last statement there, Matthew, it could easily pop out elsewhere. And so those costs are actually just replaced somewhere else. And it sounds like on some occasions it could easily be within our community mental health teams, or indeed even worse if they relapse quite dramatically, and they could end up on some of our inpatient units. But that is to be seen. Sue.
Yes, echo, I understand the financial constraints at county council level, but where does the duty to care for these people exist? Or is there no duty and it was just something people were doing because they wanted to do it?
Matthew, would that be?
Yeah. Okay. So the view of the local authority is that this would sit outside the realm of statutory services, which must be commissioned and provided by a local authority, and that's true. It also sits outside of the type of services that have to be provided by the NHS. This is about ensuring that socially excluded individuals can have the best and most productive lives possible. That was always the intention of the commissioning of the service, and some of the people on this screen have been around a long time and are aware of the genesis and the beginning of the service. As an NHS provider, we have an obligation to provide rehabilitative services, and a part of what we're doing, part of what we're looking at, is how we can adapt some of our service offer to reach somewhat into this space. I have to be clear, though, that we cannot directly re-provide the scope and the level of this specialist service that is now being lost to the system, though.
Okay, thank you, Matthew. I think it's just factually accurate that it's not a statutory duty, yet everybody agrees that it's a great service that helps people within our society. It's the position we find ourselves in, and the County Council and the system find itself in. Thank you very much. Okay, with that, thank you for that report, Sarah. Congratulations to Denise and John on taking on your new positions. And thank you very much from April the 15th, and obviously Robert as well. We look forward to working with you all in your new positions. Okay, we can note that report and move on to the board assurance framework. And before I hand over to Jill, just a reminder to all that we will revisit this again at the end of the meeting to see if there's anything that we've discussed or seen that we feel should be reflected either within our board assurance framework or in our risk registers. So, Jill.
Thank you, Mark. As board colleagues will be aware, we've been doing a lot of work about risk management following the feedback from the CQC over from last summer. We have now received the report that we'd commissioned from Good Governance Institute. They were doing a number of areas of work, and the final part of that was a review of our risk management processes. And we're now working towards taking a revised risk management strategy to the April audit committee, incorporating some of the recommendations that the Good Governance Institute have made. We've been doing a lot of work with services and functions about training and raising awareness of risk management and trying to incorporate this into the everyday responsibility of our leaders. And that's quite a significant part of the recommendations from Good Governance Institute about conducting a training needs analysis and being very clear about the expectations of team managers, ward managers, service leads, etc. Just in terms of other areas that we're looking at, we have been doing work in terms of our governance around risk management and ensuring that we have a consistent approach across the services and functions for review,
support and challenge around risks, and also that people at divisional level are taking responsibility and signing off the appropriate risks for escalation. We know that one of the areas that has been a challenge has been at times risks have been percolating up that on the face of it don't appear to be risks that should be at board level. And so that is still work in progress, but we are looking at instituting new processes around integrated governance at divisional levels, and risk management is a significant part of that. The board assurance framework that you've got there, we have 6 significant risks on there that will impact on our ability to achieve our strategic objectives. Those 6 remain and haven't changed. There's obviously been some tweaking around the mitigations, assurances and gaps relating to those. Part of the feedback from our internal auditors when they conducted a review of our risk management framework or our assurance framework was a greater focus on the target scores and what we were doing to achieve that. And so there will be a little bit of tweaking as well relating to the risk management strategy to make that more explicit and address that. We also have in the report the higher level risks, and I recognise that on there I think we've still got some work to do to make sure we absolutely have the right risks coming through. That remains work in progress, and it's something that amongst my executive colleagues we're actively discussing and trying to make sure that actually those things have that we are seeing the right risk come through both committee and board. So I'm happy to take any questions, although if we've got questions on specific risks, I might need to ask some of my colleagues to answer those.
Thank you, Jill. Sue.
So on the ongoing top risks, can I just check what we're seeing? So we have the identification of a risk and its severity and who's sort of managing that risk. And then we have sometimes the causes and consequences, but we don't have there the how the risk is managed or mitigated. So is that the bit that Mark just said we're going to discuss at the end, or is it lying somewhere behind that? Because what one reads is that, for example, in Herefordshire, there's a risk to patient safety because of mental health vacancies, and that sort of causes an alarm. But presumably there are workarounds, or are there not? And are we just saying we are failing in that area and we just need to know that we're doing so?
I can see that other colleagues have come in, but if I just say that what you're seeing there is a summary, and we've tried a couple of different mechanisms for displaying the information in the most accessible way. We there have included a summary of what the risks are and the potential consequences, and as you say, the scoring and how often it's been reviewed. But what it doesn't demonstrate on here is all the information about potential mitigations or controls or the action plan that's behind that. What I can do in terms of looking at this is as to how we can better identify some of those mitigations. On that particular one, I'm sure John would be able to comment about some of the mitigations and controls we have in place, because John and I have had a discussion about that particular one. But I'm happy to look at the information and how we present it, because what we've tried to do is move away from the printouts that we use at the committee meetings that have on there the mitigations and the controls, because it was getting to be a very lengthy document, and it was becoming inaccessible in terms of some of the clarity of information. But I'll certainly take away as to whether we can make that a little bit clearer in the information that we present.
Thank you, Jill. And before I move to John and Sarah, who are showing, that equally applies to the risk below 1415 with regard to section 47 of the Children's Act and the named nurses. And I think it would be useful just to indicate, not the full mitigate, but to indicate mitigations are in place and progressing, something to assure both board and if there's any public viewing of our papers, which I know are on our website, to demonstrate it's not just sat there as a risk, there are activities taking place as well. John, I assume you'll be able to comment on the Herefordshire vacancies.
Yes, I can, and I'll give you a bit more detail around that, Sue, and hopefully answer your mitigation question as well. So this particular risk went on in January when we had some unpredicted sickness and retirement, unpredicted people just retiring suddenly. And at that time, we did find it difficult to get appropriate agency locums immediately in place. And therefore, we put it down as a potential risk to patient safety, but more around effectiveness and patient experience. But since then, we have managed to get some agency locums in. And as you know, we do have a significant vacancy factor in Herefordshire. 63% of our doctors there are either substantive or on fixed-term contracts, and rest are covered through agency locums or through the insourcing arrangement we have, which was signed off by the REMCOM committee. So we are, as we speak, reviewing this risk, and the score will be much more lower, and the risks are mitigated quite effectively. So you don't have the detail around the mitigation plan here, which you will find on the main risk register.
Thank you, John. Sarah, and then if Sarah's not going to comment, if somebody else could comment on the risk below Sarah.
Yeah, my question was actually going to be for an update on that from Natalie, but I know she just had to step out just very briefly to start the Kind Life session, and I'll be back in a minute, because I did just want to bring this to the board's attention, because this is really, really important. So this is around our contribution to safeguarding meetings, giving a health input for children in need. And we have had some temporary extra cover for this, which has been really important and really helpful. I believe that additional resource is stopping from the 1st of April, but Natalie's in very active meetings about what the solutions might be around this at the moment. So I'm afraid I don't have more of an update unless Rob does, if anything happened while I was on holiday last week. He's put his hand up, so he might. But just to bring this to the board's attention, because this is a really important risk.
Yeah, but Rob, before you come, if necessary, we can. When Natalie comes back, I'm happy in the agenda just to go back and revisit it, because it's a really important issue. But Rob, did you want to speak about that before I go to Sue?
It was that, yes, Chair,
yeah.
And it is work in progress. So essentially, there was additional funding as we came out of the pandemic to increase capacity. At the moment, as you'll know, we've got the item later. We're very much in the process of agreeing as a system the financial planning parameters for next year. The capacity around safeguarding is very much a live conversation amongst partners at the moment. So we'd anticipate we will get to some sort of conclusion around this in the next 2 or 3 weeks.
Thank you, Rob. Sue.
Yes, well, I was going to say that Natalie and I had a bit of email correspondence about this prior to the meeting, because we talked about it briefly at Quality and Safety, and it is a really key thing for schools to have the support of the medical professionals when they've got children in need. So she is very active on it, and she knows that it's an area I'm interested in. Okay,
thank you, Sue. I suspect all that conversation noted by Jill in terms of if we could just have a little bit more just to give us some indication, because when you read them just on the plain sheet of paper like that, they can obviously be quite alarming, so a little bit of explanation would be of use. Okay, can we agree the BAF and the high level risks as they've appeared and presented by Jill, and then we will revisit at the end of the meeting just to see if there's anything else that we should add. Yeah, okay, thank you very much indeed, which then takes us on to Trust Priority Programme. Sue.
Thank you, Chair. And it's quite a brief item. I think the paper is self-explanatory, and as ever, it's a very high-level summary, which has a lot of activity going on behind it. So just to extract some of the work we've been doing on Arise, that's a key trust priority around recruitment and retention. Gaining a lot more traction now about the clarity of what we're doing next and setting the trajectories, and that will come through in the next round of reporting. This is obviously overseen by the Workforce Committee. Pleased to confirm now that we've got confirmation of the funding for the virtual ward rollout. We know that's a key plank in our system plans, so obviously that will start to mobilise. And if you want more information on that, I'm sure Rob's available to give you a steer. The Getting It Right First Time programme, again, a lot of work happening there. The public engagement is now completed. I attended a couple of sessions. The one in Worcester was really well attended. So I'd like to thank all the people that contributed to that event. We had partners, experts, carers, etc. And it was a really useful session. So now we're collating all that we've heard from that. It'll go through now for further refinement, and the options will start to emerge out of that process, and they'll be coming back to board in due course. And then finally, it's just to note that the community mental health transformation continues to be embedded as being business as usual. We're seeing so much opportunity in that work, working with our primary care network colleagues and the voluntary sector. So it's a really good piece of work in terms of the vision now mobilising forward to really support people around that neighbourhood model. So I think happy to take any questions, and I'd hope that the paper's very accessible because we've tried to make it as succinct as possible.
Tessa.
It's not so much a question, just a very, very minor detail. So where you've got the workstream 1, the Arise programme, we've got introduction rather than introduction and induction, I think it should be. We've got so many acronyms around, but I think it's important that it's stated correctly at that point for people.
Yes, well spotted. Thank you very much, Tessa.
Okay, and just on that one, that Arise programme, obviously we're down at assurance level 2. That's the one that we really need to try and turbocharge because it touches all areas of our trust, and I know they're all priorities, but that one really there needs the turbocharge, and I think we're in the blocks to do that with Elaine and the team, and we'll be pleased to see that push ahead quite strongly. Vina.
On that point, Mark, as Sue mentioned, I think the next piece of work really is to get those trajectories tied down, because without those, we have no idea how much progress we're making, whether it's having any effect, etc. Sue, you mentioned that we should get those trajectories in the next round of committees, did you say?
Yes, we've now got a programme manager dedicated solely to the Arise programme, so that's fantastic. And also pleased to see that Hannah Mayle has now taken on, Hannah Wilson, actually, that's her previous name, that's a long time ago for those of you who remember. So yeah, Hannah Wilson has taken on the chair of the Arise programme board, so put some additional capacity. As we know, Elaine's directorate has got a lot on at the moment, what with all the work we're doing around culture and equality, diversity and inclusion. So we're all leaning into this as an executive team, and as you say, Vina, that real headline piece is, are we clear on the baselines, are we clear on the trajectories, and absolutely explicit on the actions associated with basically turbocharging this, as Mark says, and then we can have a better understanding about, are we really getting into the detail of what's working here. So that assurance is going through to PMB, Programme Management Board, at the end of this month, and then it will come through to the next cycle of committees.
Okay, thank you, Sue. If there's nothing else, we need to note that report and also agree the assurance levels that Sue has allocated there, which seem reasonable. Got nods all round, so thank you, Sue. So if we move on now to item 13, which is the Care Quality Commission report and our improvement plan. And this is an item which we'll take in a rather unusual and different way, if I may call it that. We as a board here have been living and breathing the CQC, their visit, the report, our subsequent action plan for probably up to now the last 12 months. But of course, the report has only been published to the public and to our staff more widely as part of the public at the end of January. So a sort of reminder to board, if I may, before I then move to Sarah, and Sarah will unusually use some slides as well in the board. And although the slides will contain things that we know, we need to recognise this is a public meeting. We are accountable to the public, and therefore it will be easier for the public to understand what we're saying about the CQC in its report if we use some slides, or Sarah used some slides, rather than relying on the public finding our papers, which are indeed on our website. But a reminder to board that the CQC report and the result and action plan, which is now in place, they are belong to and they are owned first and foremost by this virtual table, collectively and indeed individually. We, the board, both collectively and individually, are the leaders and the leadership of this trust. And when reading the report about our trust, we must and do own every single word of the CQC report, and it's our responsibility to do all within our powers to correct our past failures, for that is what the report identifies. It's a difficult truth, and it's disappointing, and on occasions I'm sure it hurts us individually and collectively to see our failures laid out by that, but that is what they are, and that's what we're going to address. But that in a way is the past. Board's future activity is about owning our improvement plan and ensuring we deliver it, and deliver it I know we will, because I've seen the intent certainly over the last 6 months has been really determined to turbocharge this and improve our trust for the benefit of patients and indeed our staff. Sitting around this virtual table as we are today are all the skills and leadership capabilities required, but it will take absolute focus and a relentless pursuit of these improvements and to achieve the excellence we desire, and I'm fully confident that will be the case. And I know we all accept the fact, but to remove any doubt for those that are viewing our meeting, the buck starts and the buck finishes at this table, virtual table as it is today, with us, the board. We are the leaders, and it is us that need to demonstrate that we're going to deliver. We owe our patients and our staff nothing less than that. So with that, over to you, Sarah, to introduce the report and to go through some of the detail.
Thank you. The report is a very helpful summary of the journey we've been through and through to the next step. So I do sort of commend it to everyone. And also, I think it's useful to share with a number of our stakeholders and colleagues who might be asking about our journey. So just bear that in mind when you're reading it. We can take questions on the detailed report at the end, but I'm just going to run through a summary. Thank you, Jill. If I could have the next slide, thank you. So I just wanted to remind everyone exactly where we are in terms of rating now as a trust for the CQC. So our overall rating requires improvement, as you know. I just wanted to highlight the matrices though, and there's 2 of these, so they're not all on this page, but just highlight the matrices and which services were visited, because as you know, the inspection we had was a well-led inspection of the whole organisation, but it was also a targeted inspection to 4 service lines. So what you see on the matrix from the CQC is each service with their current inspection rating, but it also on the CQC matrix highlights when that last inspection was done, and it does vary quite a lot. You'll see that a couple of the services haven't been inspected, or you've got one there on this slide, but some of the services haven't been inspected for many years. So it's now clear on the matrix which inspection, which rating refers to. So in terms of this inspection that was held between February and June 2023, the areas inspected were the top line there, which is acute wards for adults of working age and psychiatric intensive care units. That has been rated as requires improvement overall. That is an overall improvement because the previous score for that line was inadequate, and that was as a consequence of the visits to Hillcrest and subsequently our acute wards that happened in the previous year. So that score has improved, but clearly it requires improvement, so it needs to improve a lot further. You'll see as you come further down to the bottom of the columns, the community-based mental health service for adults of working age was another service that was inspected. That has improved from inadequate, which dates back to an inspection in 2019, through to requires improvement now. I think it's fair to say after the inspection in 2019, the CQC did return and was satisfied with our improvements that had been made. But at the time, they were unable to change the rating because of they needed to do a full inspection to be able to do that. But this does show an overall improvement from the 2019 inspection, which is positive for them. The two services that have gone down, one is on this table, which is mental health crisis and health-based places of safety, which has gone down to requires improvement. And if we could see the next slide is also our community-based health services for adults, which has changed to requires improvement. I think this is one we were quite disappointed by because the service got very positive feedback at the time of the actual inspection, but there was a number of what I might call governance issues that led to a requires improvement rating around things like whether the documentation of clinical supervision was sufficient. So that one has changed. So if I could go to the next slide, it just shows you our rating overall as a trust, and I just think it's important to get this in context. So all of the green areas are rated good. The white areas are rated outstanding, and the amber colours, as you know, requires improvement. And we have one inadequate on acute wards around safe, and that is related to staffing and workforce levels. So that's to give you the overview, but I just wanted to be really clear that these services were inspected at different times, not as one comprehensive inspection. And you'll see on the right where our overall rating needs to improve. We remain good for caring and responsive, but we are now requires improvement for safe, effective and well led. And those are the areas we really need to target in our improvement plan. Thank you, Jill. If I could have the next one. So just a reminder that the inspection was conducted between February and June. The service visits were at the February end of the inspection, February into March, and the well-led was more in June, but it was over that time period. You'll all be aware that we got verbal feedback very quickly at the end of the inspection, and the board took on board that feedback and owned it straight away. As Mark said, some of the feedback was difficult, and whilst we knew the areas that the CQC raised and we were already working on a number of them, we weren't expecting the full breadth of feedback that we had from the CQC, having visited our staff and talked to a number of our patients and carers. So disappointing for the board, as Marcus suggested, but I just want to reinforce and thank the board really for your complete ownership of the issue since that point. And I think it's fair to say we've taken it really, really seriously since that time. Scott, as you know, who's with us today, commenced as an improvement director to focus entirely and ensure we had the capacity on the improvement plan. The benefit of Scott coming to work with us is Scott brings an independent view, being a member of the ICB, so it connects us with the ICB and our partners in the system and means that we have additional senior capacity to drive through our improvement plan, and someone who can check and challenge us in terms of whether we're being fair and appropriate, areas we need to focus on more. And my thanks to Scott, because Scott has spent a huge amount of time talking directly to members of staff to hear their views. And that's really important to me, because that means that staff can feel more safe and confident in raising any concerns they might have with Scott, which they've done so, and that gives us a really, really good foundation for our work moving forward. I'm also grateful to the ICB who supported Scott's secondment over to the Trust as Improvement Director, and also to all of our partners, because just a reminder that our partners have been involved in the process, and Scott has done a number of workshops with partners to ensure they can also check and challenge, but not just check and challenge, but share their best practice so that we as a trust can learn from their insights into where we are as an organisation and what we need to improve. The staff engagement process followed. There were around 700 staff in the end who directly inputted into those conversations. The conversations are still ongoing. I think our intelligence from staff continues to grow. And I think the whole process, personally, has led to some much more open and engaged conversations with staff around, this is what's been raised by the CQC. What's your perspective on it? What do you feel we need to do? We also have taken external advice and support on a couple of areas where we feel we needed specific expertise and intelligence to review our position further to CQC comments. So that included the Good Governance Institute, who were commissioned to review risk management systems, and the Cultural Change Programme that was commissioned from A Kind Life around compassionate culture. And the elements of our approach are going down to parallel but linking parts of the plan. We have an action plan that is very specifically the must-dos in the CQC report to make absolutely sure those specifics, like recording of clinical supervision that I mentioned earlier, are clearly addressed. And then the trust improvement plan, which is much broader in terms of cultural change. Thank you. If I could have the next slide. So the headline areas, as a reminder, from the CQC were around board challenge and visibility, and that was around whether there was sufficient constructive challenge from the board and whether the board and senior leaders were visible enough in the organisation. And I know the board, through our development programme, we've picked up a number of those issues to talk more around what does that mean to us all, how can we change that, what do we need to do differently. The second key area was around culture. The CQC saw areas of closed culture and felt we needed to work towards an open culture more. The third area was around equality, diversity and inclusion, and that was specifically focused on race equality, but we have approached it in the improvement plan in a broad way, race equality focused, but also around inclusion more generally. The fourth point was around risk escalation and moderation, and specifically around whether risks were appropriately escalated from frontline staff up to the board through the senior leadership structure as appropriate, and also how we were overseeing and moderating risks through the group that sits centrally to make sure that we have a level of equity in how risks are being assessed. The fifth area was around speaking up, and the CQC position was that our staff still felt that we needed to do more around this, and that they may be aware of processes of speaking up but may not feel confident to do so, or may not feel confident the action will happen as a consequence. And I've put one specific down because I think it's really, really important, but this came out more significantly through the visits, was around the need for us to focus more on sexual safety on mental health wards, and that very much aligns with the improvement programme in this area that we have underway. Thank you. If I could have the next slide. So where are we up to? So just to touch on the external advice, the Good Governance Institute work, the review of risk management systems and escalation has concluded. Jill has very recently received that report, which we will be discussing shortly in board meetings to agree how we want to address these. But just as a summary, some of the key recommendations were around training needs analysis, around risk management training for all levels of staff involved in assessing risk, a request for us to update our risk appetite statement, which we have reviewed as a board since this point, to review the risk moderation group. I think we'll need a further discussion on this because it's partly around leadership of that group and how we make absolutely sure we're clear what can be managed at a service level and what at a trust level. And it also recommended that we adopt a set of KPIs for risk management processes, and in the report GGI have made some suggestions on this, and I personally feel they're quite helpful, so it'd be good to have some more discussions at board around that. The Cultural Change Programme offered by A Kind Life, the Leadership Development Programme has been mandated for all 600 leaders around compassionate culture and leadership. That programme actually started yesterday, and I believe Natalie nipped out earlier just to start the session today. But there are 3 elements to that session. As you'll all know, all board members are going to do the whole programme alongside our leaders, but everybody with a leadership or supervisory role is going through this programme so that we have a core baseline level of understanding around the culture we want to see. It's also been supplemented by a number of pieces of other work we've done around things like the behaviour framework. And we're also engaged with a number of national programmes, sexual safety I've mentioned, the National Culture of Change programme, with a view to us potentially being early adopters and being heavily engaged in that work. And just to note, The governance is via our committee and board structure. Quality and Safety and Workforce Committee are both looking at elements of the improvement plan, and the improvement plan is reported through to board and will continue to do so. Thank you. If I could have the next slide. So just briefly to outline the 6 elements of the improvement plan, we have 6 work streams. The first one, compassionate, inclusive culture and equality, diversity, inclusion and equity, ED. We have a number of actions. Well, we have a lot of actions under each of these work streams, but these are the priority ones. So that includes the training and awareness I've just mentioned. It includes a refresh of the EDIE strategy and relaunch. This is really, really important piece of work. And just to note, because we are refreshing the trust strategy in the spring into summer, we will look at the EDIE strategy in that context as well. But we felt it was really important to make some clear statements about where we were on EDIE and then feed that through so that it becomes a golden thread through the strategy refresh. There's a work programme in there around encouraging freedom to speak up and addressing some of the points I've mentioned, recruiting the champions and making sure it's accessible. We want to specifically do work around anti-racist organisations and how we can make sure our culture is fair and just. And I've mentioned the behaviours framework, which is very much around the behaviours we want to see. And the board will be aware that framework has been developed following direct feedback from staff about the behaviours they want to see. So this isn't a top-down framework. This is a framework based on all of the feedback we've had. The second work stream is about systems and processes, and the key parts of that are around triumphant leadership model, which we're working through and currently about to pilot, and about strengthening our integrated governance systems and getting real clarity around decision making and structure. Those processes are already in place, but it's about really strengthening and embedding them. The third work stream is about standards and accreditation, and I think it's really fair to say that prior to the pandemic, we had quite a lot of national accreditations for different services. Some of those have, they're not lapsed, but some of them obviously have got a time limit on them, so they've come to an end during the pandemic period. And what we want to do is refresh this, that the best guide of our performance is a national accreditation and benchmark against best practice standards, and we want to make sure that for every possible service we have, we're adopting this approach of getting some external accreditation for the service we offer, alongside making absolutely sure we embed regulatory standards. And this applies to corporate and support teams, as well as it applies to clinical teams. So some of you will know that the IT team have recently got accreditation for the help desk. We know that a lot of our clinical mental health services have previously had the National AIMS accreditation, for example. So it's across the board. We're talking to every single service around what would be the appropriate best practice benchmark. Thank you. If I could have the final slide. Which is just the final 4 work streams. So the next one is on communication and organisational planning. And this, again, is really critical to the improvement plan, because this is exactly the issues we were talking about in the patient story with Jackie earlier. This is about how do we really, really listen and act on feedback? How do we really make sure we're getting that live patient and carer voice into what we do and our governance and our thinking and our planning and our redesign, and making sure it's embedded in everything we do. The 5th work stream I've already mentioned is about risk management and board development, and that will build on the review we've had by GGI, which the board will be cited on and considering very shortly. But it's also about that broader piece around how we work as a board team, how we lead, and how we give very clear messages around our behaviour and our commitment to inclusion. And then the final work stream has been added around corporate and administrative services. And this is because in the early work we did, it was very clear that while clinical services were quite prominent in the discussion, rightly so to a large degree, but really, really important that our corporate and admin services feel that their voice is heard, because they're an absolutely critical part of the team and enabling us to deliver effective services. So that work stream has been added to make sure that that element of the feedback and listening is really prominent to our thinking as well. So thank you. Sorry that's taken slightly longer than I planned, but that gives you a complete walkthrough of where we are. The detailed report gives you commentary on the next steps, where it outlines the focus for the next 3 months. There's quite a lot of points in that report, so I just draw your attention to those, and we will continue to report improvement plan progress to each board and to the committees each time moving forward. Thank you, Mark. Open to questions, and I'm sure Matthew and Natalie and others are happy, and Scott are happy to answer any questions you might have on the detailed report.
Thank you, Sarah, and I appreciate, colleagues, that this has been our bread and butter for the last minimum of 6 months, really. And our new colleagues that joined us, I think, last May, I suspect that the majority of what you've heard about is CQC improvement report, action plan, and all those sort of things. So none of the content of the report or Sarah's presentation will be new in any way to us, I guess, or it certainly shouldn't be. But I will have one question, which I think I'll ask first, whilst other people are thinking. Scott, whilst I notice on the screen you're looking away, you're described by Sarah rightly as seconded from the ICB with a degree of independence. And it's easy to read words on paper. It's easy to see from the written word what should be done. But I would like your view on how it is going in terms of, we're just about to enter a very major delivery area now, aren't we? We've been formulating, putting together, engaging with staff. I would like your view on the delivery potential for us to really turbocharge this, to move this forward from you having engaged across the organisation and worked with the board and senior leaders over the last 6 months.
Yeah, thank you, Chair. It's obviously, so I've been here just about 8 months now, and it's been a really positive experience working in the organisation. I think I'd start with saying the staff voice and the way staff have given a real open and honest appraisal of the challenges that they experience. That has provided examples which have articulated what it is we need to do differently. My experience of working with exec colleagues around unpicking those has been really positive. For example, myself and Rob went through a couple of examples yesterday which pertain to process, but also the approach we put in as a leadership team and what needs to be different. So I think the key thing I'd say is about there's been a real openness to the challenge and also a good ownership of the issues. Critical going forward is the understanding of the real importance of the changes of the governance structure, which Matthew is leading on. How all the agenda, a lot of the agenda play into that governance structure. So the collaboration around the design of that and making sure we get that right is going to be absolutely critical. Overall, in terms of the trust's ability to deliver this, yes, there's a lot going on. People are really, really busy, but I've been really heartened by by how many people have signed up for the Kind Life training. Yes, it's mandatory, but we haven't had to use the mandatory ask of people. There's a real willingness of managers coming forward, recognising that, that they want to be involved with this. They want to get things right for their staff, and they want to get things right for their patients. So I would say it is going to be a bit of a journey. There's lots to do, but the motivation and the collaboration is what will get us through all the work that needs to be done.
Okay, thank you very much, Scott. And with that, we'll move to 3 non-execs that wants to make points or ask questions. Martin, Janet and Tessa. We'll start with Martin. Thank you, Martin.
Thank you, Chair. Really, my question is along the similar sort of lines, but in terms of, before we get into the finances later in the agenda, that this is the top priority for the Trust in dealing with the issues raised, that we have the capacity, capability and financial support identified and committed in order to deal with the challenges we have ahead.
Can I ask Rob to comment on that, please? And you can put on whichever hat you like, Rob. Your new to be hat or your existing hat, but I think you should be well placed to give us some assurance around that or otherwise.
Yeah, absolutely, Chair. Happy to do that. Yeah, so I suppose the first point, Martin, and I think this has been written strongly through all of this, and everyone's expressed the point. This is front and centre of what we're doing. So actually, there is an element here around people understanding that it'll be in the business plan Sue's talked about, and it's a key area we will prioritise resource into. So there is an aspect here about prioritisation of what we do, and helping folk to do that. The second point about resources specifically, yes, it is absolutely part of the trust plan that we are just drawing together at the moment. We have the item a little bit later, but we've got specific resource identified. We identified resource last year, and we have other things in there that are very much linked to this. So part of what we're doing for the coming year is we're investing resource into supporting the Arise programme as well. So it is all very much linked and lined up, Martin.
Thank you, Rob. Janet.
Yeah, thank you, Mark. Yes, I wanted to say that, obviously we have regular reports about the improvement plan to the Quality and Safety Committee. And in fact, we did have 2 extraordinary meetings of both Quality Safety and the Workforce Committee to really crawl over the detail when that plan was being pulled together. And certainly at the last meeting of Quality and Safety, we gave it a very good going over and very thoroughly. But I think that the point I wanted to make, which I don't know if it's a question or not, is that although the CQC report was the impetus for bringing this together, I think I'm right in saying that we're doing this now because it's the right thing to do. And I think we're all really signed up to it and very enthusiastic about it. And I think the thing we need to focus on is the impact on patients, because that's actually, why we're doing it. And I suppose maybe if I can just ask for assurance from somebody that actually we are monitoring that, so that we will know that we're having a positive impact on the care that we're delivering for our patients, because I think that's really why we all come to work.
Thank you, Janet. Scott, you've raised your hand, and you were going to be the person I was going to come to ask about how we as a trust are assessing success or otherwise within our improvement plan. And that I want that if you could offer comment, or somebody else offer comment from the patient perspective. We can see on the piece of the paper when actions have taken place, but how do we know that the action has had the desired effect with staff or patients, and how are we going to look at that? Could you comment on that, please?
Yes, thank you, Mark. That there is absolute determination that this will not be a tick box exercise. So success will be through the eyes of our staff and the eyes of our patients. We are using the Pulse survey, which goes out every 2 months, to monitor the staff's view of experience at work. With the range of training that's going on, again, the staff experience that, what they feel they can put into practice. Staff will also be supported through reflective practice sessions to really take that forward. And when I'm saying staff, that is all of us. So we will all be going through its reflective practice. One specific piece of work, and I think Sue will probably come in on this as well, is where we developed the behaviours guide with there was almost 700 staff in the end who were involved with developing that. Sue's team is now doing some work to develop what would that look like through the eyes of the patient and carers. And both Healthwatch Worcestershire and Healthwatch Herefordshire have offered to support the monitoring of that. So including it in their survey work, so that we can really have that clear, independent view of the cultural change we're making, the behaviours that we're saying we're wanting in our organisation are following through into the patient experience. Perhaps Sue, do you want to come in on that and talk about the wider
yes, I suppose
work?
it's And to reiterate what Janet said, you know, we recognise that we wanted to put the focus around staff, but that's with the consequence of really making sure we give the best possible patient experience to our the public and our patients and carers specifically. So yes, we've got the work we've been doing with Healthwatch, who I'd like to thank for being with us right from the beginning of this journey. We've started to align our engagement activities, so we have got quite a number of teams across our system that are out talking to all communities and some of the communities that don't currently come into services, which is equally as important in our journey in terms of making sure we really do have accessible services that reduce health inequalities. So the behaviours work, the activity, we're pulling through themes which will then go into the integrated governance process that we were talking about earlier. So it's a real track in relation to the services specifically and how it's feeling for patients. A key plank of that is also the rollout of care opinion. So that's now rolling out with teams that have always historically struggled to get patient experience data back into their planning and processes. We've obviously got the friends and family test, and we're looking to bolt on some very experiential questions. How did it feel today? Did you feel listened to today? And that we're going to be then bringing that through. The real piece for me is we've got a lot of engagement work happening across the trust. We've got youth board, we've got the community engagement panel. It isn't tethered in enough. So that's the piece, and the reset with the governance is really making it explicit then, service by service. How do you know how this feels for patients and carers, and how will that feed into your quality improvement programs and your planning priorities? So it does feel like it's really coming together, and that obviously then, Janet, will come through to Quality and Safety Committee.
Thank you, Scott. Thank you, Sue. And thank you, Janet, because I think that question strikes at the very core of why we are doing what we're doing. So spot on. Thank you. Tessa and then Vina.
It won't surprise you that my question comes from the workforce perspective. Scott, we've done an awful lot to ensure that we're listening to our staff and that we've got representation from across the whole organisation. One of my concerns has been that how we are feeding back to the staff. So it's all very well to listen, but are we sure that we've really got systems and processes in place to tell them what they've told us and what we're doing about it, so that they know what to be looking for and what to be expecting from the behaviours piece and from the other part? And my other piece is, are we confident that we've lined things up effectively time-wise? If I can just give a very, very quick example, we're pushing the freedom to speak up. We're telling people time and time again, freedom to speak up is one of the routes in. And I think more recently we've seen people using a slightly scattergun approach in by contacting all sorts of extra people and the Freedom to Speak Up Guardian, which isn't wrong. However, my concern is, have we got the processes in place to ensure people understand what that means? Because our Freedom to Speak Up Guardian does not have a magic wand, and she can't make the managers, the leaders, the supervisors work in a way that, you know, she can't just go in and say, you've got to do this, and they'll do it. So are we confident we're marrying up the skills training for our leaders and our managers and our team leaders to deliver what is required to make the cultural changes happen? And I know that's a big question, but I think the communication piece is going to be crucial.
Yes, it absolutely is. So I'll answer that question in parts. And I think the freedom to speak up piece actually exemplifies why we need to do some of the work, and also the reason we're doing the work we are. With freedom to speak up, at the moment, only 44% of staff are reporting they're confident something will happen if they speak up. That is partly due to do with the way the response that comes in when they do speak up. It's partly about hearing about others' experience, but also it's partly about how issues are dealt with in general, and how they, people sometimes get exasperated. The regular channels haven't worked, so they've moved through to speaking up. So there's a whole myriad of things here. So in order to resolve that, I'll start with the governance structure. So that needs to be operating effectively so that issues are understood and effectively managed. We've literally just done started a piece of work about, with freedom to speak up as an example, but as well as the routes through psych, EDIE as well, regular workforce data. A group has been set up to triangulate the information that's coming in about where the hotspots are, what are the themes. Natalie and Matthew have chaired a meeting with the ADs and the SDUs around what are the themes where being experienced when people do speak up. And there are things in there that when people speak up, we need to react differently as managers and leaders. So that's a piece that Natalie and Matthew are working on with the ADs and through the teams there. But importantly then, the next step is about plugging that into that governance structure so that the themes are dealt with as well within the SDUs. So it's about individual response and making sure that we're addressing that and allowing speaking up. And it's about the systems and processes, structures, the governance, making sure that themes are seen and understood in the right areas. How do we know that we're making an impact on that? Obviously, there's staff feedback. Obviously, Debbie is here from from the staff side perspective. Debbie and colleagues are engaged with providing us feedback about what they are seeing as well. So it's those kind of things about how we are approaching turning the dial on that one. The overall communication, there has been a lot of communication, but we can never do enough. Fee has got Fee and Sue have got a comms plan which supports the communication of this, but we've started to now build a web page whereby some of the success stories and experiences are going to start to be shared. There has been regular communication through the staff, through Sarah's weekly email, and also there's been a series of direct communications as well. I do reflect, though, that we do need to do more in this space. So communicating the training, what's coming next. These are areas which are very much on Sue and my radar about doing more of, because, our staff are busy. We need to be doing things in bite-sized, quick chunks that give them the information they want. And staff are saying at the moment they're still not quite getting that. So there is still more work to be done.
Thank you, Scott. I'll go to Veena before we then close this item, and I'll sum up. Veena.
Thank you. And just picking up on those points that have been made by Tessa and Scott, excuse me. One of the challenges I think that we have unearthed, and I've had a number of conversations with Scott about this, is that it's all very well as communicating a fantastic behaviours framework, etc., telling staff how the behaviours we expect of them and the culture changes that we're hoping to see. But our managers need to have the skills to be able to address those incidents and occasions when people fall short of those expectations. I'm not sure that development and training has been in place to the level that we would like. I am told that we don't have a magic money tree that would ensure that everybody gets this training immediately, but it is something that we've recognised, and we know we've got to address it. It's not fair on our staff, and actually it's not fair on our managers that we expect them to be able to respond perfectly on every single occasion. So we do recognise that there's a gap there. Also, going back to the point around how do we know whether any of this is making an impact, we are relying very heavily on staff feedback, pulse surveys, staff surveys. The obvious risk here is that we're all sick of surveys. I noticed that in the most recent staff survey, I think our return rate was something around 43%, which doesn't compare favourably to the national median. So, it's something that we've got to be honest about. People are bored of these sort of approaches, but there are other metrics and figures that we need to be keeping an eye on. So, whilst we don't have the data internally, research has told us time and time again that when people are unhappy at work, they're more likely to take time off sick. They're more likely to be looking for other jobs. It's going to have an impact on turnover. So actually, if we do this job well, our absence figures and our turnover rates should look different in a year's time. So I think there are other areas that we should be looking at rather than just the surveys. I'm going to stop before I lose my voice now.
Yes, thank you, Vina. I know. For those that don't know, Vina's got a heavy dose of what she described as man flu, and so she's not very well at all. So thank you, Vina, for struggling through. Scott, is there a need to respond to that? Do you have something specific?
Just acknowledgement really of the impact that we want to achieve there, and there certainly are metrics that we would measure. I think the only bit I'd add to that is that the difference in a response rate. Now, we need to be seen to hearing that feedback and acting on it. That will then encourage more people to respond, because they recognise that we're hearing and acting on. So the response rate in itself will be an indicator that we're moving in the right direction. The last Pulse survey, or the last two Pulse surveys, so we jumped up from about 10% response rate to 18 or 19% Pulse rate. Which is good. But we need to keep on going and recognising that we need to be seen to be acting on that feedback.
Thank you, Scott. Okay, if I could just sum up. I mean, first and foremost, there's no group of people next door or somebody else that's going to deliver this. It's us. Okay, and every conversation I've heard, whether that be collectively like this or one-to-ones that I've had with everybody on this screen, it absolutely demonstrates the commitment and the determination to deliver this improvement plan to ensure the lot of our patients and our staff is better. So I have absolutely no doubt the right people are around the table to deliver this, and we all accept not only that we have to deliver it, but we accept the difficulties that are there, the reality of the position. We're attempting, and we will be doing this in one of the most financially challenged times the NHS has had for a long time. Yet that doesn't diminish our intention or diminish our drive and enthusiasm to do it. And one of the things I note from the plan and from those discussions is how we are also focused on making sure what we do isn't superficial. It's embedded, it's sustainable for the future. And of course, by doing those two things, it does take time, it does take longer, it does take more thought, and it does take it does create more difficulties. It would be probably easier to do something that gets you superficial results that disappear within 12 months. We don't want that. This is about improvement for the organisation in the very long term. And I know that's part of what Scott has been doing, hence the engagement with over 700 members of staff, because this isn't us doing it to the organisation. This is us engaging with the organisation, speaking to the organisation, and recognising what the organisation thinks we should do, because we are part of that organisation, and then acting on behalf of that organisation, but with the right people around the board. A couple of specific things I would say to board is, obviously we are emblematic of our behaviours of which we've agreed. So those behaviours we must model at all times and in all engagements with our staff. Even when the chips are down, we're all human, so we all will err, we all will make mistakes because we're human. But we must model those behaviours across the trust whenever we're engaging with any of our staff. And the one specific, I've not seen a comms plan, or if I have, I've forgotten. That would not be unusual if I've forgotten something. But I think that comms plan should have its tyres kicked a little bit in a committee of the board. So I'm looking at sort of Scott or Sue, it will be in your area of work, Sue, for Fee to bring forward the comms plan. And I think, would that go to Workforce? Would it, Sue, or would it Q&S? I'm not sure where it goes. It doesn't matter where it goes, but I think it would be useful that the plan of how we're going to address a lot of the things that we've heard, and the communication, and that communication is circular as well, how we hear back and also how we communicate through the organisation. It would be useful for a committee of board to kick the tyres on that, so we can seek some assurance that that comms plan that we all agree is fundamental to what we've talked about has had some good challenge and check on it. So can I park that with
I'll pick it up, Mark.
Sue stroke Rob as the new chief executive to make sure we pick up and we bring forward. And I'm not quite sure where comms go in our committee structure, either QNS or Workforce. I'm not sure which one. And just to mention to colleagues who are unaware, the staff survey has obviously come in, and we're going to hear some analysis from our provider this afternoon. But Vina and Tessa have already organised a specific workforce committee with one item and one item only, because of recognising the importance of the staff survey and the items that were picked up about how do we feedback, how do we demonstrate that we're doing things as told to us by the staff. So the workforce committee is meeting sometime in April on a specific one item to do exactly that. And the last thing I'll say before we move to the recommendations within the paper is to thank board. Myself and Sarah and what will be Rob are being held quite strongly to account for this by ICB, by region, by CQC, and it's fair to say we feel the heat, and rightly so, because we've got a job of work to do. But I feel 100% supported by board members in this, and I hope Sarah would nod and feel the same, and Rob moving forward, because it will sit very squarely in Rob's lap as Rob and I sit down, I think it's on day 1, 2 or 3 of his tenure to discuss, as you would expect, chief executive, chair, moving forward over with a new chief exec, and this will sit right foursquare in the middle of the work that we're doing, and I feel very supported by board, so thank you. So to move to the recommendations which are in the report, I presume we can all accept the CQC report as presented and Sarah's report around that as presented. Do we all accept the content of the improvement plan and the improvement plan as presented and discussed? And the direction of travel as we're being asked to look at of the improvement plan, I see nods around the screen, because we've all been fully part of this. Scott is suggesting that we have, I presume it's Scott, it could be Sarah, it could be Natalie, I'm not sure, or all three of you, an assurance level 4 on our improvement plan in essence. Are we all agreeable with that based upon the commentary as contained in the report? And we look forward to that moving forward and up the scale as we implement. Yes, that's all agreed. Okay, colleagues, difficult item and will be a key focus of what we do moving forward. We've taken some time on it, rightly so, because it's perhaps the most important thing that we're doing in the trust over the next year or two. Thank you, colleagues. We'll move on to the next item, which is of equal importance and feeds very clearly straight into our improvement plan. And that's our equality, diversity, inclusion and equity strategy that I know has had the tyres kicked, to overuse the analogy or the metaphor, by Workforce Committee, and has been through a number of iterations and a number of people have seen this. But over to you, Elaine.
Thank you, Mark. What I would say, I think we have covered with some detail the spirit and intent of our EDI policy. What it is a reaffirming of our commitment to ensuring that EDI is stitched into the fabric of everything that we do as an organisation. We've talked about the number of people who've been engaged around this, over 700, and the intention is that it is not just a strategy on paper, but it is a strategy about outcomes and impact. But what I would say with our strategy, the focus over the next 2 years is around our staff experience. And there is clearly a relationship with what happens to our staff and the impact that it has on our patient care. Our intention has been to be practical yet stretching, but also authentic in what we're trying to do. So what I would say is it's linked to our cares values. Everyone knows that. It's about our leadership framework. And I think perhaps the most important part of it is we are starting at what our staff are telling us, but also our commitment as a senior leadership team. And I think the inclusion of EDI objectives for all of us on Gallery has been an important part of that. This is a strategy that is live and organic. We're going to be monitoring it and adjusting as we learn and grow with it. We're not coming to this as experts, but we're coming to this with a real commitment to make a difference, and that's the intention behind it. In terms of governance, this will go through our Quality and Safety Committee. It will also go through the Workforce Committee as well, and there are a number of other stop points where we expect to have regular check and challenge. It's here today to be approved formally, approved in principle at Workforce Committee, and I'm happy to take any questions. But my sense is I think we've talked to a lot of what is included and embodied in the strategy itself.
Thank you, Elaine.
So any questions?
Any questions from anybody? Again, this is another one of those ones that's been around the houses, and so board members have seen it. I don't think there are any questions. A couple of comments from me, Elaine. Thank you to you and the team. I know this has been, on occasions, a painful process to try and get it right and to get it meaningful. And I think what has come forward now is a usable strategy that we can deliver, we can implement to make the staff, staff experience, as you've indicated, better. So thank you to the team for doing that. Biraj, you have a question?
So, sorry, I wasn't quick enough to put my hand up before you spoke, Mark. It's just a couple of points for my own curiosity, if I may. Firstly, there's no mention of the acronym BAME in any of this, and is that on purpose now? Are we not using that expression anymore?
Yeah.
Is it out of fashion, or is it because this is a much broader paper tackling a much broader issue rather than just simply about minority ethnics? That's my first. Sorry, go ahead.
Yeah, so to respond to that, I mean, the term BAME has been around for a long time, and there's been a lot of conversation about its relevance and whether or not it's a catch-all term. I think in truth, we've moved on from the term. We talk about minoritized or ethnic minority communities in rather than say black, but BAME just takes away from the individuality and quality of the conversation. So in short, we've moved on. We talk about minority ethnic communities or racially minoritized communities, but that's not to the exclusion of other protected characteristics. So I have purposely not used the term BAME.
Okay. Yeah, I'm very happy with that. I don't like the expression. As a member of an ethnic minority, I don't like that expression anyway. But we've used in this paper instead, we've used minority ethnic / gypsy traveller background. So again, I'm just trying to clarify, well, what you just said, you just used a completely different phrase just there.
Yeah,
Elaine.
The sounding barrage comes from the communities themselves. I mean, we had initially just talked about racially minoritized. Now, the traveller gypsy community may not feel racially minoritized, but they're a minority nonetheless. So we have to name it as preferred by the group themselves. As I say, I think language is a moving feat. Some might see that as part of the woke minority, or we're being politically correct, but we must take a sounding from the communities who are impacted by this, and that's what we're doing. And to my earlier point of this being a live document, if we were to get continual feedback about, well, this particular group don't feel like this, then we have to take a sounding and be responsive to that. But that's where we are at the moment. We will continue to keep this under watch and be responsive as we can.
Great, thank you. My other very quick point, sorry, Mark, is about perhaps the very little or no mention of networks. I'm a big fan of staff networks. I think they can mobilise staff that either wish to be part of that network for whatever reason, whether they belong to that category or not, and for the organisation to use the information that staff networks can glean from their membership. I wonder whether we're missing a trick by not engaging, or at least this paper suggests we're not engaging in as much detail as we could be with our networks.
Yeah, and perhaps probably, whilst not explicitly stated, our staff networks are an integral part of this strategy. But the devil's in the detail, as they say, but definitely part of the equality reference groups, part of the staff networks. They are an integral part of the strategy going forward.
Thank you.
Thank you, Pete. Elaine, would there be opportunity just to give you the responsibility to do it, to ensure that staff networks might just need a sentence somewhere, whether it be in monitoring what we're doing or enhancing, before we publish this. I know that it's going to be subject to amendment potentially because we have a trust strategy refresh across the summer.
Yes, yeah.
But I think Beej makes a good point. So maybe somewhere, if you could just have a quick look at
we can make that more explicit.
And see if we can make it more explicit.
Yeah.
There are no other questions and points, but I think the discussion you've just had with Beej almost exemplifies the difficulties we can encounter in terms of it being a moving agenda, but also it's a model of how we should do it. You ask the question, whether it be about terminology or anything else, you ask the honest question because we know we're all here in good faith and we have good meaning, and you get the answer, and we try and then model those behaviours and use the appropriate terminology as it moves forward. And I think Elaine's point is very well made about making sure that we listen to minority ethnic communities and other communities as to what terminology they are comfortable with. So, Elaine, thank you. Board, can we agree this subject to Elaine being delegated the authority to make those changes to include staff networks as she sees appropriate, and then we can agree it as published, to be published? Yeah, there's nods all round, Elaine. So thank you very much, and please pass on our thanks to the rest of the team. Okay, so that's agreed. We move on now to item 15. What I intend to do is keep going till about wherever we are at 11:15, we'll have a break because I think we've had quite an intense morning thus far. So we'll get to 11:15 and then move on. Matthew, operational update, please.
Thank you. I'd like to draw board's attention to the following points. We are continuing to experience bed pressures for our mental health adult beds. That has a bearing on our achievement of the national standards for inappropriate out-of-area placements and our local recovery plan trajectories with regard to that standard. All of our core capacity is open now. So Hillcrest is open to 14 beds, which is the maximum we can reasonably get out of the footprint and safely deliver care. Currently, we have 4 inappropriate out-of-area placements. The cause of our bed pressure at the moment is a large number of people in beds who are not needing acute hospital care at the moment. The reasons for that are very similar to acute physical healthcare hospitals across the country, which is that we've got people who are waiting for specialist housing, specialist care. We have to source funding and we have to seek placements. And that has a timeline which is typically longer than somebody's acute care needs. At the moment, we're experiencing anything from 20 up to 34% of our bed capacity used by people who no longer need to be in hospital. So that's been up to 17 people. Today it's 15. We would expect to have 5 to 10 beds available in our core capacity. So if we work through to normal levels of delayed transfers, that's what we'd have today. We'd have 5 beds open, we'd have nobody out of area. We're working very hard to ensure that we identify people who are going to have potential problems leaving hospital when they're discharged at the 72-hour point. So we've introduced a new process whereby the multidisciplinary team work to formulate outgoing plans of care when somebody's been in hospital only 3 days, identify problems and work towards solving those. That's in line with the National Commissioning Guidance, which Sarah mentioned earlier in her report. We introduced a new escalation process as well. So we're having daily discussions with senior managers, executives and clinical leads and the consultants responsible for individual patients in order to try and help people move out of hospital who no longer need to be having care in an inpatient bed. I'm confident in saying we've got plans for everybody who's currently delayed, and we're working on plans for those who are potentially delayed. We mentioned earlier enablement services, and I've spoken somewhat on that, as has Sarah. I met with staff personally 2 weeks ago, so that's 10 staff who are affected by the closure of this service. we're working with staff on redeployment, and we're confident that we will retain all those staff, and we're working with them and the teams who may be receiving them, in order that we can ensure that we retain their skills and the general approach that they've taken with service users, even though the service will not be continuing. We've finished as an organisation our formal challenge. We've been given notice on this service, but I would ask board to note that our clinical leads in services, including community consultants, continue to make representations to HOSC and to other formal bodies in relation to their disappointment at this service discontinuing. On to urgent and intermediate care. You will probably have noted in national news that the NHS England has set targets for all systems for the achievement of the emergency access standard, which is 76% nationally. Worcestershire have agreed to work towards a goal of 73%. You'll note as well our strong contribution as a provider to intermediate care in this area. So we're working together with our provider and commissioning partners. And I'll say we're working very effectively together as a system and continuously reviewing the effectiveness of our approach. Obviously, working towards acute flow priorities comes with somewhat of a cost to the delivery of our standard care. So neighbourhood teams are continuously reprioritising their standard care delivery, as we discussed in Quality and Safety Committee. That does have the implication, of course, that as we move resource towards meeting daily priority needs in the system, some patients who have standard appointments have those rescheduled, and in some cases rescheduled several times. We're working at the moment with Droitwich, Ombersley and Rural's neighbourhood team, not mental health team, sorry, who are experiencing challenges with high travel times due to the rural nature of their provision, the proportion of newly qualified nurses and their workload volumes overall. Executives recently met with the team on a formal risk summit and agreed a plan with them which will be closely monitored through the risk summit process and through local integrated governance arrangements. Children's services, we're continuing with our internal CAMS review. The outputs of that are around standardising the care that we deliver, decluttering our offer somewhat, especially in Worcestershire. We've got a large number of smaller teams which probably could work together more effectively and ensure that we're operating to best standards of clinical practice. We're working with the ICB at the moment on the redesign of the Tier 2 offer, so that's non-specialist CAMS services, and we've begun this ourselves with the completion of our review of our Reach for Wellbeing service, which has been reviewed and is now operating in a slightly different model. And to note the good news about the significant improvement in paediatric speech and language therapy waiting times as a result of the implementation of the balance system. We're now national leading around those, so achieving all under 18 weeks. And that balance system review continues now for other paediatric therapies. Note as well that we've also secured funding for a specialist epilepsy nurse in our learning disability services, which will enhance the service we're able to provide to children with complex learning disabilities and epilepsy needs.
Thank you, Matthew. Does anybody have any questions there at all on that? Sue?
I wondered if I get a chance to do it before 1:15. There's some really positive things there, Matthew. I would like to, it's commendable that Children's Services Tier 3 CAMS have no waiting list in either Herefordshire or Worcestershire. What about the pressures on Tier 2? And with regard to the single point of access that you have in the Herefordshire Early Intervention for Psychosis, or Anchor, or CAMS, CAST or West, it talks about a professional needing to do that, and I wondered, what do we mean by a professional? Does that include an educational professional? And what happens when we have children or young people who are Gillick competent and could potentially refer themselves, but it seems to be that they have to have the parents or carers' permission.
Okay, there's quite a lot of questions in there, so I'll try and unpack them one by one. So in terms of our waiting lists for Tier 3 CAMHS, it's not that we don't have waiting lists for Tier 3 CAMHS, we don't have waiting lists for specialist CAMHS services within Tier 3 CAMHS. So within Herefordshire, we're meeting our national waiting list standards. In Worcestershire, slightly outside of that, but we don't have any waiting lists for specialist CAMHS services within that. For our Tier 2 services, in terms of our offer, we're meeting our contractual standards around that. However, it's well recognised that there are a large volume of children with emerging mental health problems for whom there needs to be a better and more integrated offer. And the ICB are leading a review of all of the services at that level with a view to increased investment in services for children who may have challenges in life, haven't got a formal mental health problem at the moment, but at risk of developing one at the moment, or at the risk of developing one, in the future. We're working with the ICB around that. We expect to receive an update very shortly through the Mental Health Collaborative about their progress on that. In terms of self-referral and Gillick competence, we're able to take referrals through our children's school services for children who have the capacity to refer themselves. So we're able to do that already. So if that didn't come across accurately, I apologise.
Oh, not at all. I mean, it's just trying to understand it all. But I'm just aware increasing numbers of children are now homeschooled. Often those are children who have got social and emotional or mental health issues. And it's just how they are able to access, because, it suggests that there needs to be a professional support for accessing a lot of what's on the internet. So where it talks about single point of contact, it says we will take a referral from a professional. And I just wondered, what do we mean by a professional?
Okay, so that's not so we'll take referrals from partner agencies, from education providers. We can also take referrals through our West system for children directly. With respect to homeschool children, I have to say it isn't something I've previously considered. There may well be an answer from the service about that specific point, and I will go back to the service and see if I can get a more specific answer around homeschool children.
That's very kind, because at the moment, as you probably know, there are no national registers of who is homeschooled. It's something that needs to be addressed. And sometimes children are homeschooled, and it can be a mask for things that are going on at home. And sometimes those children do need to be able to refer themselves quickly to things. So it would be a good piece of knowledge to have.
Thank you, Matthew. Thank you, Sue. Sharon, if we could just pick that up as an action in the minutes for Matthew to find out the information. I would suggest, obviously, Sue be the main contact if a discussion is required, and just drop a note to everybody on that one. Okay, can we note Matthew's report, please? And Matthew, congratulations and thank you for finding a way of redeploying the 10 staff. Looking after our staff like that, with such short notice from the county council, is exactly what we should try to do, and it looks like you've been successful in redeploying them. I know they haven't been redeployed as yet, but you're looking at it and making sure that we do everything we can. So thank you for that. Okay, we can note that, colleagues. If we take a break now, and can I ask you to come back at 11:30 prompt? I think the rest of the agenda should be more straightforward because it's routine, even though we got finance on it. But of course, we've had large discussions around that. So I'll see you all at 11:30.